Okay, is that in full screen, Dr. Yu?
Yes, it is.
Okay, super. All right. So I'm really pleased to discuss with you our recommendations on prevention and management of pregnancies complicated by preeclampsia. I will say to you that this has been an age-old problem, and we continue to work on this and rely on actually your support to provide the most evidence-based care to the women in your country and elsewhere. We know that hypertensive disorders of pregnancy are one of the leading causes of maternal mortality. Globally, it's considering the second cause of maternal mortality, but there's actually regional variation. And in some regions, it's actually the biggest killer of women who are pregnant or have been recently pregnant. You can see that one of the main things that we note is that while the relative incidence, so the number of women who have preeclampsia or diagnosed with preeclampsia, is relatively comparable no matter where you are globally, what's happening is that the women who are pregnant and developing preeclampsia in low and middle income countries unfortunately carry the larger proportion of complications and poor outcomes from preeclampsia and eclampsia. In other words, no matter where you are in the world, you're probably about as likely to develop or be at risk for preeclampsia. But if you live in a lower resourced area, you're much more likely to suffer a complication. All of you know this, but just for the purpose of completeness, basic diagnosis for preeclampsia is new onset hypertension with proteinuria and pregnancy. Those are hallmarks, and that's not the only way to be diagnosed, but that is one of the main ways to be diagnosed with preeclampsia. Pathophysiological changes, although they're not completely articulated, we do believe and understand that inadequate placentation quite early in pregnancy puts women at risk for developing preeclampsia later on in their pregnancy. And of course, the definitive treatment is the end of the pregnancy. And depending on where the woman is with gestational age, the treatment could vary. We have a set of guidelines that were first published in 2011. And there were 23 recommendations that were published at that time. These recommendations were intended to improve the quality of care and the outcomes of women. And subsequently, through our living guideline process, there have been several updates to these recommendations. So in other words, if you were to search these recommendations online, you will note that you'll find the main guideline published in 2011. And then the website will note that there have been updates to these recommendations, some of which supersede what was originally published in 2011. For your information, and because you will have access to this slide set later, I list them here. In 2018, we updated recommendations on drug treatment for severe hypertension in pregnancy. We updated the policy for expectant versus interventionist management in severe preeclampsia before term. We also published on calcium supplementation during pregnancy for the prevention of preeclampsia and its complications. Subsequently, in 2020, we updated recommendations on drug treatment for non-severe hypertension in pregnancy, the recommendation for calcium supplementation before pregnancy, and in 2021, we further updated the recommendations on antiplatelet agents for the prevention of preeclampsia. Use of aspirin was updated in 2021. So who is at risk? Women are regarded as being at moderate risk for developing preeclampsia in their pregnancy if they have two of the following risk factors: primiparity, a family history of preeclampsia, their age is greater than 40 years, or they are having a multiple pregnancy. Further, women are considered to be at high risk if they have one or more of the following factors. That is, they've been diagnosed with diabetes, they have chronic or actually gestational hypertension, they have pre-existing renal disease or an autoimmune disease. They have a positive uterine Doppler screen during their pregnancy. They have a previous history of preeclampsia, or they have a previous fetal or neonatal death associated with preeclampsia, like in the video we just saw. I want to say that this is not really an exhaustive list for moderate or high risk stratification. And based upon your local context, there might be additional ones that you would add to this. But in general, these are the parameters for when you would think, I need to pay a little bit extra attention potentially for complications such as preeclampsia in this woman if she has these conditions. So the first one is in terms of prevention. In that 2021 update, we recommend that the use of low-dose aspirin, or 75 milligrams per day, is recommended for the prevention of preeclampsia at moderate high risk for developing the condition. So all those women that were named previously. This dose of aspirin should be initiated by 20 weeks gestation or as soon as antenatal care is started. The GDG, when discussing, the guideline development group, when discussing this recommendation, really wanted to emphasize that, of course, for women who are at risk for preeclampsia, early prenatal care helps to optimize their pregnancy outcome. And certainly the sooner that you see the woman or she's seen for care, the earlier preventative treatment can be started, such as low-dose aspirin. A couple of things to note. Where aspirin in 75 milligram tablets is not available, then the dose closest to 75 milligrams should be used in its place. So if you have 80 milligrams or 82 milligrams, and that's easily found, by all means, please do use that. The other thing is, while the guideline development group did want to emphasize early initiation of treatment, the note that as soon as antenatal care is started means that if the woman presents for antenatal care at 22 weeks, 23 weeks, please do go ahead and start aspirin treatment at that time for the prevention of preeclampsia. What about other preventative measurements? We're often asked about whether or not pre-pregnancy calcium is useful for the prevention of preeclampsia. And in 2020, the guideline development groups noted that use of calcium supplementation solely for the prevention of preeclampsia is really to be done only in the context of rigorous research. But I'd like to just contrast that with our recommendation for pregnancy supplementation in pregnancy. And that is, well, there's not a great deal of evidence to suggest which amount of calcium. It is recommended that for women who are living in areas where it's quite common to have low dietary calcium, that daily calcium supplementation of 1.5 to 2 grams of oral elemental calcium is recommended to reduce that risk of preeclampsia. And that's for all women, not just those that are high risk. Now, of course, the recommendation would be to start as soon as possible. And that, again, could be when you first start with antenatal care. But you want to, the issue is that while there's a recommendation for populations that have low dietary calcium, and we speak about starting it during pregnancy, we don't really have at that time enough evidence to speak to whether or not you should continue through pregnancy, stay on it afterwards, and then be on it even before a subsequent pregnancy. So there was this was identified as an area for research. Now, let's say that we haven't been able to prevent preeclampsia from developing. What do we do? So it's very important to say that magnesium is recommended in preference to any other anticonvulsant. I say it's important to say because despite this recommendation being published in 2011 and the evidence being quite strong for this, we're very much aware of the fact that there are settings where magnesium is not either readily available or is not being used as needed for whatever reason. despite being on the WHO essential medicine lists, named on all commodities, and so on and so forth. The other thing that's important to mention is that the full IV or intramuscular magnesium regimen is recommended for the prevention and treatment of eclampsia. But where it's not possible to provide that full regimen for whatever reason, then the guideline development group did recommend that women be provided a loading dose and transferred to a higher level facility. However, the dose is given for the loading dose, so that initial dose is given. The idea is that there should be 24 hours of maintenance following that initial loading dose. I just want to show here what these full doses look like, because depending on your setting and how the magnesium comes, we are aware of that. One of the main issues regarding the ability to use magnesium is that it needs to be mixed, that sometimes these pre-mixed bags of magnesium or pre-mixed syringes are not readily available. And so sometimes, depending on if you receive magnesium as a 5 gram in 10 mLs or in two, depending on the dosage, it can vary on how many ampules of magnesium you would need. So what I'm showing you here is the number of ampules you need to actually be able to give the full Pritchard regimen, which is at time 0 or the first dose, which is 4 grams of magnesium sulfate IV with 10 grams of IM magnesium. That's 5 grams in each buttock, followed every 4 hours for an additional 5 doses of 5 grams of IM magnesium in alternating buttocks. And I want to highlight that the last dose is given 20 hours after the initial dose, because that dose is intended to last 4 hours later for that full 24-hour of coverage. This is what the Zuspan or the IV would look like, which is basically an IV load followed by 24 hours of an IV infusion of 1 gram per hour. And again, this means needing IV equipment and ideally not running by gravity drip, but by a measured drip. One of the reasons that we know magnesium is sometimes not used or healthcare providers are concerned about using it is because we know that it can cause nausea, vomiting, flushing, and drowsiness. But we're also worried of the fact that at very high doses, magnesium can cause respiratory and cardiac failure. And so while a little bit is good, too much is definitely worrisome and could be fatal if unchecked. But I want to emphasize here that no fancy tests are really actually needed. Clinical monitoring will work if a woman is followed clinically. What you see here is a table, and depending on your setting, if you use millimoles per liter, milliequivalents per liter, or milligrams per deciliter, for anticonvulsant prophylaxis, if you were to measure the serum level, you can see that the top line in black there, anticonvulsant prophylaxis, has a level of anywhere from 2 to 9, depending on, again, which measurement denominators you use. And you'll see the next thing in red, which is a loss of deep tendon reflexes. This is the first sign that you might have too much magnesium in the woman's system. So for instance, if you are used to measuring in millimeters per liter, millimoles per liter, the anticonvulsant prophylaxis dose is between 2 and 3.5. And the loss of deep tendon reflexes happens just above that level at 3.8 until about 5 millimoles per liter. But what you also see is that you have to really get much higher than that to have either a respiratory arrest or cardiac arrest. So almost, at least a doubling of the amount in the serum before you would risk cardiac arrest. And so it is hard to imagine that a woman who is on magnesium, who needs to be clinically followed for seizures, would not have the chance to have clinical monitoring to check if she has deep tendon reflexes. Because if she has deep tendon reflexes, and she's producing urine and therefore able to clear the magnesium, then she does not have too much magnesium. And that's really important to remember. I put here in the next slides what we mean by clinical monitoring. We've noticed from recent work that some of our colleagues have not ever been taught or are not comfortable with clinical monitoring for toxicity. And so very simply to mention, to check patellar reflexes, you need to place one hand under the knee, lift it off the bed, allow it to hang freely, and tap the patellar tendon, which is just below the kneecap, with the reflex hammer. And to check urine output, it's quite common to have a catheter placed, but these catheter bags usually have a mechanism where there's two chambers. And in the first chamber, you collect urine every hour and tilt it into the full bag once you've measured what that hourly output is. And if the woman has been making 30 milliliters of urine per hour, she's actually making enough to clear magnesium from her body. People also worry about IV side effects. And while these can be bothersome, they can be recognized and managed. So for instance, one might have bruising. It's quite common on the left. It's a pretty significant set of bruising. And on the right, you have phlebitis from the IV, where there's basically been extravasation into and outside of the veins there. Again, these are uncomfortable. They can be managed symptomatically. You can switch the IV to the other side. Now, IM injections carry with them their own side effects. All of you will know that 5 grams into the bottom is not really so comfortable. And you can have bruising like you see on the right. That would be fairly common. But an abscess, which is on the left there, which is indurated and might show up quite a bit afterwards, could be quite painful and needs to be observed carefully. All of these are known side effects, but we must consider about the risks and benefits of treatment. And all things taken together, magnesium, however it's provided, is still the best treatment to prevent and treat preeclampsia or eclampsia. Now, let me just move on to the treatment of non-severe hypertension. So women who develop non-severe hypertension should be offered antihypertensive drug treatment in the context of good antenatal care. So in other words, women should have their blood pressure checked. And if we start seeing that the blood pressure is becoming elevated, then treatment can be offered, but it needs to be in the context of, you will follow this woman up. She's not going to disappear, because you may have to titrate the medication. The most common treatments are methyl-dopa and beta blockers like labetalol, and they are good options for non-severe hypertension. And both of these, of course, can be given orally. I think the issue that we often see with methyl-dopa is that it is a medication that you have to take at least twice a day, if not up to 4 times a day, and compliance can be a bit of an issue, whereas sometimes we can do better with labetalol, which can have a less frequent dosing schedule. Now, what about women who have really significant hypertension with a diastolic that's closer to the 100s range? To be clear, the treatment for high blood pressure, however severe it is in pregnancy, is not done to prevent preeclampsia, it is to actually help the woman and prevent side effects from the woman, for the woman, due to uncontrolled severe hypertension like stroke. And really, the choice and route of how you want to give the antihypertensive drug really depends on what you as the clinician feel like you are comfortable with, and what is the local availability and the cost for that drug in your setting. So there is flexibility there, but the idea is to, again, titrate the blood pressure. Now, you don't want to go lower than her baseline blood pressure. And so typically you will titrate so that the blood pressures will get to about 150/90. That's about where you wind up settling your treatment to. Now, once you've been following this woman and she gets to term, whether or not she has mild or severe eclampsia, it is to deliver. And so the question then is timing of when you want to have childbirth occur. If a woman has mild preeclampsia or mild gestational hypertension, then an induction of labor is perfectly reasonable. Now, a woman who has severe preeclampsia at term, the guideline development group used the terminology early delivery. And that is that somebody who has severe preeclampsia, you don't want them to have a very prolonged induction. You really want to get on with delivery in the shortest time frame possible. That said, cesarean section is not the only, preeclampsia is not the only indication for delivery by cesarean section. That is taken into account everything else that's going on for the woman and her pregnancy. So a couple of points here in terms of that timing. If you have a woman who has severe preeclampsia and you don't think that she's going to achieve a viable gestational age within 1 to 2 weeks, then rather than waiting those 1 or 2 weeks to try to get to something, because you will never get to viability, it is recommended to actually initiate induction of labor right then and there. Now, if you have a case of a woman where she has severe preeclampsia, she has a fetus that is at a viable gestational age for your setting. So that might be 24 weeks, that might be 26 weeks, that might be 28 weeks. A policy of expectant management that is watching and waiting is recommended, provided that somebody can monitor her for signs and symptoms of either increasing maternal organ dysfunction or evidence of fetal distress, such that delivery can be effected soon thereafter. And for women who have severe preeclampsia and are between 34 and 36 weeks, again, you can watch and wait, but you really do need to be able to watch to action towards delivery if there's any sign of trouble. And above 37 weeks, again, the move is towards delivery. Just on the point of what to do if you are considering expectant management, at this point, remember that for the purpose of the neonate who is at risk for preterm birth, we do recommend that antenatal corticosteroids are provided. So if you think that this woman has severe preeclampsia and you want to try to manage her expectantly, please do remember to give a dose of corticosteroids between 24 and 34 weeks. And you should give this course of steroids, be it betamethasone or dexamethasone, even if you think at some point I won't be able to complete the full dose of therapy. One is better than none, and any amount of exposure is better than no exposure to antenatal corticosteroids for that neonate. Once the pregnancy has been terminated with induction, C-section, so on and so forth, women who needed an antihypertensive medication during the pregnancy, that should continue and again be titrated. And certainly those who have severe postpartum hypertension that sometimes it can also develop even afterwards, should be treated again using the drug that are available and that the clinician is most comfortable with. Typically, when women have hypertension that's developed only in the pregnancy, you will see that you're able to titrate and decrease the dose of the antihypertensive and stopping it by about 6 weeks. But those who have severe hypertension, or certainly those who had hypertension that developed quite early, where you think actually it was chronic hypertension, they're likely to need antihypertensive drugs for a much longer time period, if not until continuously, and need subsequent care by a general physician. Before I end, I wanted to just mention a couple of things. There are some interventions that we don't recommend. That is rest at home for the full sake and only sake of preventing preeclampsia. Strict bed rest, again, only for prevention of preeclampsia. There may be other things that are going on in the woman's pregnancy or her pregnancy status that might imply that increased rest might be useful. But remember, strict bed rest actually can put women at risk for thromboembolic events, and so that is not recommended. Nor is restriction in dietary salt. Of course, all individuals, all women, pregnant or not, should have counseling on what is considered good nutrition, and that is limiting and not having excessive amounts of dietary salt. Now, there's always a question about what to do about supplementation other than calcium, such as vitamin D, vitamin C, or E. None of these are currently recommended for the prevention of preeclampsia. There is research going on, we're aware of this, but at this current moment, there are no changes to these recommendations. The use of diuretics like diazides are not recommended for the prevention of preeclampsia. Now, if a woman has already been on a diuretic for whatever reason, there can be consideration of continuing it for that indication, but with strict monitoring and also understanding about whether or not the diuretic is the best drug for whatever she was being treated for. So in other words, if the diuretic was being used outside of pregnancy for the management of hypertension, there are better drugs that can be used, such as I named before. But if she was on a diuretic for another reason, you could continue that, but the idea is not to start a diuretic for the prevention of preeclampsia. The last thing I want to mention is the use of corticosteroids as a treatment for HELP, which is the elevated liver enzymes and hemolysis and low platelet syndrome, which is on the continuum of the hypertensive disorders. It is not recommended to give corticosteroids for managing HELP, and that is to be distinguished from the use of corticosteroids for the neonates' benefit when they're at risk for preterm birth. Okay. There are some areas of research that remain open, and as I mentioned earlier on, despite the fact that we've known about preeclampsia and preeclampsia and eclampsia for a long time, we don't know everything about screening. We don't know everything about what kind of educational or community measures might be best. We don't know what is the minimum of that magnesium dose that I mentioned earlier. We don't really know the effectiveness of the drugs for acute hypertension and the subsequent effects on the fetus and newborn. And in terms of self-care interventions and the management of non-severe hypertension in different settings, these remain areas where we don't have the best evidence or very high quality evidence. And lastly, one of the recommendations that I mentioned earlier, which was on the timing, and dose of low-dose aspirin, that was mentioned that we recommend 75 milligrams of aspirin per day for the prevention of preeclampsia. There's actually a trial starting that's going to be looking at whether or not 75 or 150 milligrams actually is more beneficial. And so that's a head-to-head trial that will answer this question once and for all. And that is just happening now in several countries. And so I want to just bring that up in that this shows how we don't know everything about preeclampsia. We know what helps now, but certainly more innovations can occur. And as they do, and as we gain more evidence and more understanding about the effects of these interventions, our recommendations will change and evolve to reflect. So with that, I just want to thank you for your attention, and I will stop now. Thank you, Dr. Yu.